The challenging thing with babies is you can't get them up and walk them around the unit.
Welcome back to PedScript. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C. Zach, what are we talking about today?
So today is part 4 of our VV ECMO deep dive. In this series, we span the entire VV ECMO course from the decision to cannulate to higher level mobilization protocols like extubation while the patient's still in the pump.
Yes, it is so good. And we're also lucky that we're not just talking about the PICU today. We have both a pediatric intensivist, Dr. Jenna Miller, and a neonatologist, Dr. John Daniel, to really help make sure we're not ignoring those neonatal considerations.
For Dr. Jenna Miller, she's an Associate Professor of Pediatrics at the University of Missouri, Kansas City School of Medicine. She's the Director of the Pediatric ECMO Program and Director of the Pediatric Critical Care Fellowship Program at Children's Mercy Kansas City.
Yes, mental note, she is the Critical Care Fellowship Director. Dr. John Daniel is an Associate Professor of Pediatrics at the University of Missouri Kansas City School of Medicine. He is a practicing neonatal cardiac intensivist and the Director of the Neonatal ECMO Program at Children's Mercy Kansas City.
Let's jump right into part 4. This might be a good time to transition our conversation to mobility and rehabilitation for these patients on ECMO. Mm-hmm. So to catch you back on our case, we have, over the next several days of your service week, the neonate and the adolescent patient have both done well. And you're interested in working on mobility, rehabilitation, weaning ECMO flows. So let's go ahead and dive in. First thing, why should we care about mobility and rehabilitation with these patients on ECMO? Like, why is it so important?
Mm-hmm. So there's a lot of studies that suggest mobility improves our outcomes for our ICU patients, both physically and psychologically. Those outcomes include shorter hospital durations in some studies. There are also really good studies that talk about pediatric patients specifically and mobilizing in the ICU and that is safe. And so I think we all know that on some level, mobility, wakefulness, interaction with families is a good way to avoid global deconditioning. And that's not helpful for our patients in the ICU and thereafter. And so what I mean by that is there was a New England Journal study that actually talked about monitoring patients 5 years out from their ARDS episode. And while they had pretty good resolution of pulmonary symptoms, they still perceived that they did not have the strength and the endurance that they had before their acute hospitalization. So we can be really good at getting them through their cardiopulmonary problems, but they still have issues just from their ICU stay. And so I think that's why it's important, because we want to try to, heal the whole person, not just their lungs, which are obviously a very important part. But if we're going to get them through this life-threatening event with respiratory failure, then being mindful of the rest of them, I think, is valuable to the patient as well.
So when does this start, and what does mobility and rehab actually look like for the patients in your PICU?
Mm-hmm. So my timeline is similar for most patients, meaning that if they're on neuromuscular blockade, this comes off. I start to wean my sedatives early and monitor if I'm able to support them on ECMO, because that balance can take several days, and for some it can take weeks, honestly. And so making sure that they are comfortable, spontaneously breathing, and supported by the pump is a little bit of a dance. And so that can take some time, but that's why I try to start working on it in the first couple of days. And some patients are able to come through that and start doing mobility within the first 48 hours, depending upon why they're on. So for neonates, some people think about, well, how is mobility applicable to neonates? So same thing, waking them up and letting them move around is important. If you can get a neonate extubated, they can work on oral stim so they don't lose those skills, because that's, one of the most important things that babies do is eat. And then we've had parents hold the babies, so get them out of bed and have parents hold while on ECMO. So right now, those are our mobility activities for our neonates, but John would tell you that he has visions of hopefully being able to breastfeed on ECMO one day, so that is one of his goals for his NICU population, and really for our population too in the PICU, because we see older patients that still breastfeed. So, that's one of our pie in the sky goals in the near future.
Oh, that sounds very nice.
Yeah.
What do you consider the motor milestones to be as you start to liberalize your sedation depth and move towards early mobilization in the school age adolescent kids?
Sure. So the first things I want to see is them just to start to be awake and spontaneously breathe. From there, can they move around in bed, help adjust themselves in bed, start to sit up, first assisted, then unassisted. Getting them the bed bicycles where they can bicycle in bed if they're old enough to be able to coordinate that. Playing games. So some kids will sit and play Uno, some will shoot hoops from the bed, and all of that is kind of on the way to regaining trunk support, head control for some kids, but trunk support so that they can pivot, start to dangle on the side of the bed, maybe start to lift some weights, and then get out of bed. So we have something called, I call it the cardiac chair. I think it has some very fancy names, but that's what I call it. And so they can sit in that chair and we'll slowly start over the course of days to kind of bring them up to stand so that they can weight bear and stand while being supported. And then from there, they can kind of step away from the chair and start to take some steps. Ultimately, they might walk around the room. They might walk around in the hallways. We might take them out in a wheelchair and wheel them around in the hallway so they can kind of get out of their room. And so those are the kind of the physical steps from, just being awake and breathing all the way to, regaining the strength to be able to stand up and walk. And while we don't walk every VV patient by any stretch of the mind, it's always our goal to work towards it. So we're always working towards that. And so my most recent asthmatic patient I had sitting on the side of the bed by day 2.
Oh, wow.
So she was up and awake, extubated on the side of the bed, dangling on day 2. So that was really great for her family too, who was obviously very scared.
Yeah.
And then some other kind of mental health things that we've done for our kids is, like I mentioned, they can play games. We've had some virtual reality systems that they've been able to use. We brought their pets in. They could do some art projects. So all of that is, I think, very helpful, like I said, for their mental health, their psyche, and also for their parents as well. So.
Yes.
It certainly is obvious to see how this could reduce delirium if you're putting a patient with familiar faces in front of them, maybe even a pet or a familiar activity. But I'm so fascinated just thinking about extubating this patient or liberalizing them from the ventilator so they can do these things. Will you give us some comments about how you think about using perhaps an early tracheostomy or even extubating a patient to facilitate this mobility and rehab that you're talking about?
Mm-hmm. Absolutely. So first of all, mobility and extubation are a team effort. So obviously the patient is the leader, but the physicians, the ECMO specialists, the bedside nurses, respiratory therapists, physical and occupational therapists, our psychologists, speech therapists, really everyone has to be on board and trained how to get these patients to move around and how to support them while they're extubated. So when I think about an extubated patient, again, that varies by the patient. So for an asthmatic or somebody with a large air leak, I try to extubate them immediately because any amount of ventilator support is causing barotrauma. So I will extubate them as soon as possible. For kind of a general ARDS patient, somebody who's been on really high vent settings and neuromuscular blockade and all these things for maybe a little bit before going into cannulation, I'll do that over the course of a couple of days. And to bring in kind of the CT and the bronch data here, if I'm looking at lungs that are completely consolidated and airways that are pretty clear, I think this might be a longer process, and I'll absolutely work them towards taking the breather tube out. So each age group is going to tolerate that differently too, right? So talking a 2-year-old versus a 12-year-old through an extubation is different. And so we want them to be calm, but not sedated. As I mentioned, we want them to spontaneously breathe and protect their airway when they're extubated. So finding that balance can take a little time. And then I'll usually extubate to either nasal cannula or high flow. And people are like, well, why? Because their lungs aren't doing anything. I understand. But it does sometimes seem to provide a little bit of psychological support to the patient. Like, okay, I have this thing here. I'm getting a little bit of help. Sometimes it helps the parents. Sometimes it helps even bedside staff who are anxious and they have something they can, provide a little more oxygen for if the patient is having some troubles at some point. So again, that's just my own personal practice, and oftentimes when they are on for a long period of time, they'll just take it off and just be on nothing. So that's usually kind of the steps that I'll take to try to get them to extubation if that seems like the right thing to do for the patient, whether it's physiologically or because it seems like they're going to be on for a long period of time.
It sounds like the two physiologic milestones you're looking for to be like, yes, I'm comfortable extubating this patient with my lung rest atelectasis strategy is 1, they're awake enough to sort of clear and manage their own secretions that they won't be actively aspirating. And 2, they have the force to generate some negative intrathoracic pressure and expand their lungs a little bit, with that like a few spontaneous breaths, just a little bit of force. Is that?
Yep, they may or may not be able to move that much tidal volume, but for them to just trigger. And so that's really what I'm looking for. And they may, if you look at the ventilator, they may move 5 cc's of tidal volume, and that's okay. You can take their breathing tube out, and they may not even have enough force to be able to talk because they don't have enough air movement generated or flow generated to be able to talk, but that's okay. I want to be able to see them trigger the breath so that when their alveoli are ready to open up, they can.
Nice.
You know, the challenging thing with babies is you can't get them up and walk them around the unit like you can with older children and adults. The first thing we're thinking about with babies on VV ECMO is you don't want to keep them sedated. You don't want to keep them paralyzed. So I typically will lift paralysis as soon as we're done cannulating and really try and work on getting those neurosedatives down so that the baby is interactive with you. One of the nice things about extubating is they can suck on their pacifier, they can work on bottle feeding, and just kind of have a little more free movement without that endotracheal tube in their mouth. That's really kind of the way you rehab a baby is you feed it, because I mean, babies kind of just lie there and you feed them, and then they get bigger and then they start walking and stuff like that. So really kind of feeding and taking their pacifier and taking their bottles are kind of the things that I'll work on to try and rehab a kid while they're on ECMO.
I'm so interested to know more about the proportion of patients that you extubate on VV. Is this something you try to do with majority of your patients, or maybe 10 to 20%? Give us a better idea.
Oh gosh, Zach, I didn't look at my numbers before this.
Ballpark.
I would say for respiratory causes, honestly, we're probably closer to 50%.
Okay.
Generally speaking.
That's so fascinating.
Yeah.
Maybe say you've extubated that patient and they're doing fine on VV. You're thinking, let's start weaning our VV support and see how they do. Would like to know how that breathing tube being out affects your weaning process. And gosh, are you going to reintubate this patient to decannulate them? Gosh, so many questions.
So many questions. Again, it depends on the patient. So I keep, using the asthmatic for certain examples here, but we decannulate our asthmatics extubated. So our goal is to use percutaneous cannulas so that we don't have to reintubate them, because that is the opposite of what they need, right? When we think about asthma physiology and air trapping. So once they're clear and they, do a trial where they're exchanging gas and they don't seem to have any asthmatic features anymore, so they're not wheezing, they're not prolonged, we will just give them a little ketamine and then pull that cannula right out and hold pressure, and then we're done. So we don't have to reintubate them. Other kids, if we feel like we're moving towards a place where their lungs have opened up visually on X-ray or CT and their airways appear clear on bronch, we may reintubate those kids just to get them off circuit, especially kind of the smaller kids, just because they're obviously at higher risk for atelectasis and have lesser ability to clear their airways on their own. So we will reintubate those kids in order to get them off, absolutely. And then there's a handful of kids we will trach, depending upon if we're thinking this kid's absolutely going to need support long term and after they get off ECMO, so it'd be helpful for them to be trached now. Some kids, we have wondered if they would be transplant candidates. And so we do not do transplants at our center, but most centers want the patient to be trached and rehabbing and in a good nutritional status to consider them a lung transplant candidate. So we will trach those kids if we are concerned that is the path we are going to go down. I'd say those are probably the most two common reasons that we'll trach the kids on ECMO.
So in my mind, you're not using tracheostomies for early rehabilitation. You're extubating those patients. And you're using the tracheostomies for the patients that are going to need long-term mechanical ventilation.
That's generally what our practice is, but it's absolutely reasonable to consider trachs early. And so if your practice at your institution is lesser so towards extubation, an early trach may be extremely useful to allow the patient to wake up, especially younger patients where people are concerned that the tubes are going to come out, to wake them up and move them around. And, that may even facilitate earlier decannulation because you're able to, quickly just put them back on the vent and see how things go. So I think that is extremely valuable for many patients, and in many institutions, that could be an approach that's considered. I will just say that requires, obviously, the multidisciplinary conversation between your ENT doctors, your coag doctors. What is your process going to be to do a surgery on ECMO in a systemically anticoagulated patient? So that is something to think about in advance, as opposed to like, well, we're just going to trach this kid and walk in and and, have complications. So
It must be so impactful for outcomes, having those protocols.
absolutely, I think so.
Once I see that the lungs are starting to get better and they're getting ready to come off, and we think we're getting ready to bring them off, we'll typically try and re-intubate them at that time and just kind of see what their lungs can do. I'm a big fan of volume guarantee ventilation, and so I will usually put these kids in a volume guarantee mode and just see what their lung compliance is. If you put a kid in on the ventilator, they have 5 per kilo of tidal volume, and you're getting PIPs in the 30s, nope, just back off, take the tube out, let them rest more. But if you see, hey, I'm getting, PIPs in the high teens, low 20s, that's a good sign. And then, we'll kind of slowly back down on the flow, kind of just to see what their native lungs can do and kind of go from there. I think before a baby's ready to come off, I want to see how they do on their own. So we do something called capping the ECMO circuit, where we just unhook it from the wall. There's no oxygen going to it. And so the blood's going round and round and round, but the oxygenator's not doing anything. So the baby's doing its own thing. And I like to see several rounds of good blood gases before I'm saying, okay, this baby is ready to completely separate from mechanical support. Oftentimes, if I'm worried about their heart function, I'll take a peek at their echo just to kind of see what their right and left ventricle are doing. And if there's any kind of fluid issues that we have, are they underfilled? Are they overfilled? Do I need to get more fluid off before I can take this baby off of ECMO?
So it seems like you're going to either reintubate a patient that you previously extubated, or just, of course, maintain that breathing tube during the process of decannulation. Any neonatal specific considerations for the actual decannulation procedure?
It's just always important to remember babies are smaller, and the biggest thing you're going to do is you're going to change your volume of distribution of all of your drugs. Because, our circuits, gosh, I'd have to ask my ECMO specialist the volume that our circuits have. I want to say it's, 400 cc's or something like that, but it's a not insignificant volume for a little baby. And so oftentimes just remembering my volume of distribution is going to change massively. My drugs may have more of an effect. They may have less of an effect. Some of the drugs really love plastic and are sticking to plastic, so you've cranked your drips up. You take the plastic away, and you're still giving the same dose. And so you can sometimes over-sedate kids. I've done that quite a few times, and I always kick myself afterwards. Just like, I was over-sedating that kid, and it's just going to take more time for those medications to wash out. Really, that's the biggest neonatal-specific concern.
That's a great point.
Yeah.
Something I didn't actually consider. The volume distribution changing so much, especially your little baby, 3 kilos, maybe less.
Right.
If I'm coming onto service and it's a really long run ECMO patient that I'm taking over for, do you have a way that you would review, like, okay, we haven't really CT'd this guy's chest in a while, we haven't bronched in a while, we probably haven't echoed maybe in a few weeks. How would you clean that up coming on service?
So if I come onto service with a patient who is still stuck, so meaning they are needing quite a bit of FiO2 and sweep in the circuit, their x-ray looks pretty whited out still, then I want to go look and see, how are the airways doing? Are they open, or do we need help with some clearance? Are there new findings on the chest CT that would impact how long I think this patient's going to be on? So on occasion, like I've said, we found abscesses, empyemas, aneurysms, or evidence of lung that maybe has become fibrotic. So that is also important when you're thinking about, is this going to be reversible in the end or not? And so while no one likes to think about that part of it, it can also be helpful in these long runs to try to gather that type of information as you're thinking about, will this patient be able to liberate or not? And then echoes, like I said, I really like those at least every week on my long run patients, just to monitor how my RV is doing. And I think it's also nice to know just, where's my cannula sitting right now and in relationship to where I think it is?
Yeah. Lots of great considerations thus far about whether the patient's intubated or trached or extubated as you progress their care. I want to just focus back on the pump. What does weaning VV ECMO support look like, and how do you know when this patient's ready to be liberated?
So as I mentioned, every day when you come in and you look at your pump, and as you monitor your pump over the course of the day, you're going to be looking at, how much FiO2 and how much sweep am I using. As you start to see those things trend down, you start to wonder if your patient's lungs are contributing more to the gas exchange process. Over that period of time, you may or may not see that the lungs start to clear on x-ray, or you may start to see that first, and then you start to see the FiO2 and the sweep come down. And so those two things are really the biggest ways to monitor if your patient's lungs are starting to participate in gas exchange and if you're starting to get some alveoli that are starting to work. So as we start to see that, we may do something that we call sprinting, and it may be called different things in different places, where we might just turn the FiO2 and the sweep down to pretty low settings and just see what they do. So do they desaturate immediately? Do they look extremely uncomfortable and dyspneic immediately? Or do they kind of hang in there? And that, again, gives you a little bit of an idea how close you might be to doing a trial off of gas flow or capping, as sometimes people call that, a capping trial. So not everybody will do these, what I call sprinting trials, and people may do them more or less towards, the latter part of the run. But I think it's interesting just to stand there, have them turn it down, and just watch yourself and see what happens with the patient. And I think that's invaluable when you're trying to decide, are we getting close to a trial off of ECMO or not?
And then exactly how do you know when the patient's appropriate to decannulate? Is this when you just have the circulate FiO2 on 21% and the sweep is essentially nil, or what?
So that's when you know that you're ready to do a capping trial. So that's what we call it in our institution. But generally speaking, that's when we're going to disconnect the gas flow, really. So the patient's going to be connected to the circuit. The blood's going to go round and round, but the oxygenator is not going to really be doing anything. So all of the gas exchange, the oxygenation, the ventilation is going to happen on the patient's side. And so you're going to watch and see how well the patient does with that. So obviously you're watching the SATs at the bedside, but monitoring your blood gases and seeing how your ventilation is going. And depending upon the length of the run, you may do that for shorter or longer periods of time. So if I have a patient who's been on for, a week, 14 days, I'm going to do a shorter trial on the order of hours, maybe 4 to 6. If I have a patient who's been on for a longer period of time, months, 2, 3, 4 months, I am going to do a longer trial, and that's going to be on the order of 24 hours at least. And that's because we can see, or we have seen them do okay in that first couple of hours and then not be able to keep up in the longer term, and then we know they need a little bit more time. Also, with those long runs and those long capping trials, sometimes I'll take a quick peek at their RV and see how it's feeling with just the patient's pulmonary function. And that might give me an idea of if I should come off on the mill or no, and do I need to be monitoring that RV pretty closely when I come off. So that's kind of another caveat that I'll throw in if we are on a long run for the patient. Once they make it through that capping trial, depending upon how long it is and things look good, then we'll let our surgeons know. And, depending upon if it was a cut down versus a percutaneous, then they'll come decannulate for us.
That sounds great. And hopefully percutaneous, hopefully just a little procedural sedation if they're not intubated, or just, general sedation if they do have the breathing tube.
Mm-hmm. Yep, exactly. So like I said, if they're an extubated asthmatic, then just a little ketamine and pull and hold pressure. And if they're intubated, then obviously we can give them a little bit more. But I try to do that so they continue to spontaneously breathe through it. But it's not always possible, which is fine.
That sounds great.
After the decannulation, or sort of as you're processing what's happened with the family, how do you think about neurodevelopmental outcomes?
Mm-hmm. So neuro complications are one of the things that we do try to give people up front when we're doing consent process, should we have enough time. And it's not an ECPR situation, which is not what we're talking about today. But that is one of the major complications of ECMO runs. And so I might tell them up front, or I might tell them during the run that, there could be monitoring that we do by EEG. Sometimes we'll do CTs just for surveillance, but sometimes we'll do that if we are concerned that there's a change in the neurostatus. 5% or so of respiratory peds runs have intracranial hemorrhages, and that is associated with increased mortality. So that's obviously something that we are concerned about and need to monitor for and watch for. And then long-term or post-run considerations are that we may commonly do an MRI after the run, even if we don't have any specific concerns, to evaluate for any injuries. And it's not uncommon that we'll see a little area of ischemia or a little area that we think was injured during the run, but isn't necessarily clinically obvious for the patient. And then when we talk about the long-term data, there's description of seizures, hearing and vision problems, and developmental delays that some of these patients will experience post-run. The percentage of patients that have this varies by study. And while in pediatrics, having a high-powered study is difficult to come by, these studies are good, but their ends are all less than 100. And so it can provide us some insight into what to expect. But I think this patient population deserves comprehensive outpatient kind of standardized follow-up with neurologists and physical therapists, rehab physicians, as well as, their pulmonologists or cardiologists to monitor their acute process.
It all makes sense.
Mm-hmm.
So what evidence is there? What can we tell our parents at the bedside after these babies have a run of VV ECMO?
Obviously, the biggest advantage that VV ECMO has over VA ECMO is you don't have to ligate that carotid artery. And that is kind of the biggest benefit, because when you ligate the carotid artery, some centers will repair it, some centers won't. It kind of just depends on surgeon preference and how they put the cannulas in. The nice thing about VV ECMO and VA ECMO is actually we have really good neurodevelopmental outcomes for these kids. I often think the mode of ECMO is less important than just kind of the management during the ECMO run. Minimizing neurosedatives is probably the biggest thing you can do either way. So benzodiazepines, we know they're terrible for the brain. Versed. The drug we always use. We love Versed. Everybody gets it. But we know that it's really bad for the brain. And so in recent years, we've really started to trend away from using Versed. One of the medications that I personally really like for these kids is dexmedetomidine or Precedex. The nice thing about that drug is that the studies done in lamb models and animal models is it has a neuroprotective effect on the neonatal brain. The studies that have been done have shown that most of these kids, regardless of your modality of ECMO, have really good neurodevelopmental outcomes. You know, there's some concern with the VV ECMO that you're really taking that big cannula and sticking it in that vein, and so you're going to inhibit cerebral drainage, which can lead to problems. Always the concern is the head bleed. We always worry about head bleeds on ECMO. The nice thing is, I think the neurodevelopmental data for kids who have like a grade 1 hemorrhage as compared to who have no hemorrhage at all there's very little difference, if any. The one thing I think that the NICU does well in neonatal patients is all of these patients are going to get an MRI after they come off. Every single one of them. And they're also going to have prolonged developmental follow-up. So all of our patients, at every center I've been to, every patient that's been on ECMO gets at least 3 years of neurodevelopmental follow-up in a clinic of some kind, whatever you want to call it. A lot of places call it a NICU follow-up clinic or a special care clinic or what have you. The greatest thing about those clinics is they're multidisciplinary. They're pediatricians who are specialized in taking care of medically complex babies. They're neurologists, they're speech therapists, they're occupational therapists, social workers, dietitians. And so what we've actually found is that when we identify any deficits that we find early and we intervene with these services, we can get these kids back to close to being normal, if not normal. And so most of these clinics are going to see their kid, they're going to see a baby after discharge. And then for that first year, sometimes they'll see them every 3 months, sometimes every 6 months, but it's, 3 months for every 3 months for the first year where you're getting regular assessments and everything, and then they'll start to get spaced out. One of the pieces of our fellowship that we all do in neonatology is we do time in this clinic. We see all these kids that have been on ECMO or been micropreemies or something like that, and the benefits of early intervention services, regardless of your ECMO modality, has the best benefit for these kids.
Yeah.
Well, Dr. Jenna Miller and Dr. John Daniel, thank you so much for your time today. This has been a great conversation covering the basics of VV ECMO, but also sharing with us many of your experiences that I think will make this much more relevant next time we're at the bedside taking care of a patient on VV ECMO. Anything else that you'd like to share with us before you go?
I just wanted to point out that, I referenced a lot of material and data from the Red Book and other studies, but I also included many anecdotal and personal and institutional practices into this. So certainly I want people to know that doing it a different way or having a different process at a different institution is perfectly valid and welcomed and expected. And all of our experiences together really is what helps us grow as a community. So just wanted to give that little caveat.
The biggest point to leave everybody with is if you ever have questions or concerns or anything, just ask somebody. I can't tell you the number of times that I've gone onto my phone and in my group chat that I have of ECMO directors from across the country said, I have this baby, I need some help, give me your thoughts. Whether it's ECMO or critical care medicine or just medicine in general, don't practice in a vacuum.
Mm-hmm. That is the perfect note to end on. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening. Zach, if I ever need ECMO, fly me to Kansas City.
That's right. Yeah, so they can extubate you.
Yeah.